Welcome. I am Dhuha. I am a third-year student in Mosul Medical College. I and my colleague Sama will show our pathology seminar about Hirschsprung disease, supervised by Dr. Zahraa Marwan. I will start my objectives with introduction, epidemiology, pathophysiology, pathology, types, associated anomaly, clinical feature, diagnosis, treatment, and finally with complication. Introduction. Another name for Hirschsprung disease is congenital aganglionic megacolon. Hirschsprung disease is due to segmental absence of ganglion cells. In Hirschsprung disease, colon dilation is due to defective colorectal innervation. Ganglion cells are absent beginning in the internal anal sphincter and extending proximally for variable length. Epidemiology. In about 10% of cases, the whole colon is a ganglion. Rarely, the small intestine is also involved with Hirschsprung disease effects. 1 in 5,000 live births. 80% of patients are male, except in long segment disease where male to female ratio is equal. So the incidence 1 per 5,000 live birth newborn, 70 to 80% is boy. Male to female ratio is 4:1. Hirschsprung disease is less common in black people. Pathophysiology. The developmental sequence that leads to innervation of colon is interrupted in Hirschsprung disease. The normal caudal migration of cells from the neural crest to the intramural ganglion cells is aborted. Since the internal anal sphincter is at the far end of this migration, the ganglionic segment always starts there. It may extend variably proximally, depending on where primitive neuroblast migration halts. Given that the aganglionic rectum and sometimes the adjacent colon are permanently contracted because of the absence of relaxation stimuli, fecal contents cannot readily enter the stenotic area. The proximal bowel becomes dilated because of functional distal obstruction. This figure shows a normal large intestine with ganglion cells, and beside it, abnormal large intestine with Hirschsprung disease have no ganglion cells. Pathology. The large intestine in Hirschsprung disease has a constricted and spastic aganglionic segment. Proximal to this, the bowel is very dilated. Definitive diagnosis requires demonstrating the absence of ganglion cells on rectal biopsy. There is also a striking increase in non-melanated cholinergic nerve fibers in the submucosa and between muscle coats, neural hyperplasia. The lack of ganglion cells leads to accumulation of acetylcholine and acetylcholinesterase, which are evident using histochemical staining. Carotene immunohistochemistry aids in diagnosing Hirschsprung disease in rectal suctions biopsies. Interestingly, like achalasia, which is caused by destruction of esophageal ganglion cell. This figure shows ganglion cell in the wall of normal rectum, while this another figure shows a rectal biopsy specimen from a patient with Hirschsprung disease show a non-melanated nerve in the mesenteric plexus and absence of ganglion cells. Types. First, congenital. This type is the commonest one. Etiology of the disease is still unknown, but genetic factors are now identified. 10% of cases have familial history, especially those with long segment disease. Second, acquired. Acquired megacolon sometimes occur in children and often has psychogenic component. In adult, acquired megacolon can result from disorders that interfere with the bowel, innervation, or smooth muscle function, such as Chagas disease, diabetic neuropathy, Parkinsonism, myotonic dystrophy, scleroderma, amyloidosis, and hypothyroidism. So, degeneration of ganglionic may be due to vascular causes like after pull-through procedure due to ischemia and tension, or non-vascular causes like trypanosoma Chagas disease, or vitamin B1 deficiency, or chronic infections like as tuberculosis. For more, my colleague Sama will continue.
My name's Sama Jamal. I will talk about associated anomalies of Hirschsprung disease. Hirschsprung disease is usually a solitary anomaly in a full-term, otherwise healthy infant. Associated anomalies do occur in nearly 20% of cases: urogenital system 11%, cardiovascular system 6%, gastrointestinal system 6%, with 8% having various other malformations. Prematurity is reported in as many as 10% of those children with Hirschsprung disease. Trisomy 21 occur in approximately 5% of cases. A clinical feature: Hirschsprung disease should be considered in any child who has history of constipation dating to newborn period. 90% of cases are diagnosed in a newborn period. Most common presentation in a newborn: number 1, failure to pass the meconium in the first 24 hours of life. 98% of neonates pass the meconium in the first 24 hours of age. Any newborn who failed to pass the meconium in the first 24 to 48 hours of life should be evaluated for possible Hirschsprung disease. Number 2, neonatal intestinal obstruction. Symptoms include bilious vomiting, abdominal distension, and refusal to feed. Number 3, recurrent enterocolitis, mainly in the first 3 months of life. Number 4, toxic megacolon, including fever, abdominal distension, bile stand vomitus, explosive diarrhea, dehydration, and shock. Number 5, spontaneous perforation, occur in 3%, especially if long segment ganglionosis. Number 6, chronic constipation. Patient may have chronic constipation in response to change in feeding and may have growth retardation. Diagnosis: history, failure to pass the meconium, painless abdominal distension, and constipation. Physical examination: distended abdomen with multiple fecal masses on abdominal examination. On digital rectal examination, characteristically there is anal sphincter is hypertonic, rectal is typically empty, hard fecal mass. Abdominal X-ray using a contrast dye. Barium or another contrast dye is placed in the bowel through a special tube inserted in the rectum. If significant barium is still present in the colon, it increases the suspicion of Hirschsprung disease even if a transition zone is not identified. This method is useful in determining the extent of a ganglionosis before surgery. Anal manometry. A manometry test is typically done on older children and adults. The doctor implants a balloon inside the rectum. The surrounding muscle should relax as a result. If it doesn't, Hirschsprung disease could be the cause. Rectal suction biopsy. It is the gold standard for Hirschsprung disease. It can be performed at bedside without general anesthesia. Biopsy taken at 2 cm, 3 cm, or 5 cm above the dentate line. Diagnostic accuracy is 99.7%. Treatment. Once the diagnosis is established, the definitive treatment is operative intervention. The operative options are to perform a definitive procedure as soon as the diagnosis is done, or perform a temporary colostomy and wait until the infant is 6 to 12 months old to perform definitive repair. There are 3 surgical options. Swenson procedure excision the aganglionic segment and anastomose the normal proximal bowel to the rectum 1 to 2 cm above the dentate line. This operation is technically difficult and leads to the development of two other procedures. Domal's procedure. Domal describes a procedure to create a new rectum, bringing down normally innervated bowel behind the aganglionic rectum. The new rectum created in this procedure has anterior aganglionic half with normal sensation and posterior ganglionic half with normal propulsion. Soft procedure. Endorectal pull-through procedure involve stripping the mucosa from aganglionic rectum and bringing normally innervated colon through the residual muscular cuff. A chronic constipation treatment including laxative, saline enema, walk up to establish the diagnosis, then the definitive treatment will be planned. Before the operation, the patient rectum must be cleared by catheter. Complication after pull-through procedure including number 1, narrowing of the anus, number 2, leaking stool from the anus, number 3, delayed toilet training, number 4, constipation, number 5, enterocolitis. The references are Robin's Basic Pathology, Nelson Textbook of Pediatric, Principle of Pathology in Surgery. And thanks for listening, and we wish you a pleasant viewing with Max's story with Hirschsprung disease.
Husband Thor, and our son Max has Hirschsprung disease. We found out on his third day of life that something was not right, but it wasn't until the 10th day of life that they finally diagnosed him with Hirschsprung's disease. Hirschsprung's disease is a disease of the colon, and he was missing ganglion cells, which he needs in order to move stool through his bowels. He had his first surgery when he was a month old, but then a few months later he was still having complications, crying and pain all day, every day.
After 2 years of desperately searching for a solution for Max, these parents found Nationwide Children's Hospital surgeon Dr. Mark Levitt on the internet.
It was late, our kids were in bed, it was about 10 p.m. and I said, I'm gonna email this guy, Mark Levitt. At that time, we didn't know where he was at. We didn't care, we just wanted help, so we emailed him, and it was 10 minutes later, we got an email back saying, I can help your son.
She starts, this guy, he emailed me back. I can't believe it. They make a little fun of me about how attentive I am to emails, but I always know that there's a nervous parent or needy physician somewhere in the world on the other end.
Right then, I said, I'll go anywhere to, see him, and come to find out, he was in Columbus at Nationwide. He had just moved there.
Max is an active kid now, thanks to Dr. Levitt's diagnosis and solution. He performed a second surgery to correct the first one, which had been done elsewhere.
And I remember in the very early period after the surgery, within a couple of days, he was already functioning much, much better. And he gave me a first smile, I remember, very soon after surgery.
I'm on a Facebook support group for Hirschsprung's disease, and there's people from other countries, from around the world, from California, Texas, every state in the U.S., and they all know of Dr. Levitt. I just feel so privileged, so blessed that we were able to see him and get the help that Max needed. And Nationwide Children's gave Max a normal life, and it provided us hope when we were hopeless.
He's very bold. He kind of has no fear.
Max is 4 now, and he is a ball of fire. He loves all things sports, all things boy, and no, he doesn't let Hirschsprung's disease hold him back from anything.